Hello, my name is Rashid Al Rashid, and I'm a clinical psychology PhD student at the University of Washington in Seattle. And I'm presenting on behalf of my co authors on our study, Adherence, the Child Attention Deficit Hyperactivity Disorder Treatment Guidelines in Medical Homes, results from a national survey. In the United States, approximately 1 in 10 children are diagnosed with ADHD, which is characterized by chronic symptoms of inattention, hyperactivity, and/or impulsivity. Many of the most recent ADHD treatment guidelines recommend behavior therapy as first-line treatment for children under the age of 6, and a combination of behavior therapy and medications for youth between the ages 6 to 18. Despite this recommendation and behavior therapy's robust empirical support, many youth still do not receive behavior therapy for ADHD. A medical home is an enhanced model of care of delivering primary care that was found to be associated with positive health outcomes and patient satisfaction. However, very little is known regarding the effect of having a medical home on mental health outcomes specifically. Therefore, the goal of the study is to assess the association between having a medical home and the type of ADHD treatment children in the United States receive. We classified ADHD treatments by the following subtypes: medications alone, behavioral treatment alone, or a combination of both. Our data came from the 2016 National Survey of Children's Health, where participating parents of children under the age of 18 self-report on their child's health outcomes. Our predictor variable was parent-reported medical home status, and our outcome variable was a categorical variable for ADHD treatment types, including all of the aforementioned treatment types plus no treatment. Covariates in our model include sociodemographics, ADHD severity, and presence of any psychological comorbidity. And we conducted a population-weighted multinomial logistic regression to assess for the association between having a parent-perceived medical home and the ADHD treatment children receive. In our sample of 4,252, participating children were predominantly white on Hispanic, male, aged 12 to 17, primarily English-speaking, had private health insurance, lived in households with income greater than or equal to 400% of federal poverty level, had mild or moderate ADHD severity, and had at least one psychological comorbidity. I'll be showing a breakdown of the proportion of children that receive each ADHD treatment type based on their medical home status. To orient you to the graph, the x-axis corresponds to different ADHD treatment types, and the y-axis represents weighted percentage of children in each of those categories. For children with a parent-reported medical home, it looks like the majority receive medications alone, and not that many receive behavioral treatment alone. Now, for children without a medical home, we can see that the majority receive combination treatment, and again, not many receive behavioral treatment alone. It's important to note that regardless of medical home status, about 1/4 of the children do not receive any treatment for ADHD. It's also quite alarming that at a medical home, which is considered an enhanced model of care, appears to do a worse job at providing behavioral treatment alone and combination treatment, both of which are recommended treatment guidelines. Medical homes only outperforms in prescribing medications alone for ADHD. The following table is a sneak peek into our main analyses, showing the prevalence odds ratios of receiving each of those ADHD treatments predicted by the presence of a medical home. Since our outcome variable is categorical, we chose medications alone as our reference category to reflect the current standard of care for child ADHD. Our model, which controls for all of our covariates, reveals that having a medical home significantly reduces the odds of children receiving no treatment at all compared to medications, which is great. However, medical home presence also reduces the odds of receiving behavioral treatment alone compared to just medications. Lastly, having a medical home did not significantly affect the odds of receiving combination treatment, which is the most recommended treatment, compared to medications alone. There were also some associations between our covariates and the ADHD treatment children receive. First, children in the 3 to 5 age group were more likely to receive behavior therapy alone compared to medications alone. And then moderate and severe ADHD increased the odds of receiving combination treatment versus medication alone, and the presence of any psychological comorbidity increased the odds of receiving behavior therapy alone or combination treatment compared to medications alone. Now, in summary, parent-perceived medical home status increased the probability of children receiving ADHD medications, but not behavior therapy alone nor combination treatment. And medical homes may need to ensure that children with ADHD have access to and receive age-appropriate, evidence-based behavioral treatments as recommended by clinical guidelines. For future directions, future work should explore barriers and facilitators of providing recommended evidence-based treatment in medical homes for children with ADHD, Future work should also examine whether providers in a medical home feel confident and competent to provide or to refer children with ADHD to behavioral treatment when appropriate. And lastly, future research should evaluate sustainable strategies or quality improvement efforts that can better manage child ADHD in medical homes. Thank you for watching this video, and for more information on the national dataset we've used, please visit the following website.